No, I'm not going to choose you. All right, how long will it take, Tiffany? Be nice.
We can get a fire engine in 3 minutes, but an ambulance in at least 5.
Okay. By the time you call 911, that call goes into the dispatch center. That dispatcher has got to ask you a series of questions. Basically, kind of what's going on, what the address is, a callback number, some patient condition. That can take a minute to 3-4 minutes depending on the cards. We're working on a system with dispatch now to speed that up. It'll automate it quite a bit. But right now, you're going to be 2 to 3 minutes just on dispatch phone, or 2 minutes before they'll actually send somebody out. Then by the time those folks get to the rig, if they're in Brigham City and they're in the station, and then up to here. So you're talking 3 to 5 minutes at a minimum for right now. What's happening to that patient during that time? Yeah, there's if no treatment is being given, if no ABCs, no airway breathing or circulation is taking place for that patient, their chances of survival greatly decrease. So that's why we need first aid in the workplace. That's why we all need to learn this. Keep them going until help arrives. We call 911 for serious emergency. When is a serious emergency? Not breathing. Okay, I'll buy that one. Bleeding a lot. Unconscious. Unable to stand. Severe pain. How about stubbed toes?
No.
I've been on those. Broken fingers. I don't know what part of a broken finger says you can't drive yourself to the hospital. Cut my leg shaving. Been on that twice. Yes, they have. I've been on 2 of those calls before. Headaches? It depends. Okay, severe migraines and you're all alone. Yes, that can be. But yeah, I mean it's kind of crazy to think, but we've told everybody throughout the years that if no matter what happens, you call 911. If your pizza's late, you call 911 now. If you don't know what time the sun sets, you call 911. If you want to know what time the parade starts, you call 911. No, you don't, but that's what happens. That's the way the situation is. So, when you're talking medical emergencies, you know what? If you're in doubt, call. I'm serious. I mean, if you're even questioning, then call. If it's nothing you can't throw a Band-Aid on or wrap and take them to the hospital, then call. So, scene safety. We teach this in every EMT class, in every EMR class, every class. The first thing we got to determine, is it safe for us to go in there and help? We have a lot of different workplaces throughout the county. Probably most instances within this building should be safe, but it's going to depend on the incident. They had a gas attack in Syria this morning. There's people dead there. The explosions, the workplace violence. You got to determine, is it safe for me to go and help that person, or do I need to back off and wait for more help? Unfortunately, that's the world we live in right now. But you walk out into the road and somebody gets hit by a car. Is it safe for you to go out in the middle of the street? Can we make it safe? Can we get people to block traffic? Can we stop some vehicles? But if we go out there and bend over a patient laying on the street and start helping them, cars can't see us, can they? So we need to take a look at the scene and the situation and make sure it's okay for us to go in and help that patient. We don't want to become a victim ourselves. Legal considerations. This is always the kicker. People, I don't want to help. I might get sued. Utah has the strongest Good Samaritan law in the nation. It says that as long as you act within the level of your training, you cannot be held liable in a court of law. So you don't need to be afraid to go help. If you're doing tracheotomies and stuff like that with your pocket knife and a ballpoint pen, then you may be in trouble. But we're not teaching any of that. You're not learning any of that. But what we're telling you is, don't be afraid to help people. Don't be afraid to open airways. Don't be afraid to control bleeding. Don't be afraid to do CPR. Because again, as long as you're within your level of training, you're not held liable. You can sue somebody for anything. I can sue them for yawning in my class, but it doesn't mean I'm going to win. Yeah, you see crazy lawsuits out there all the time. but it just means they don't have a chance in a court of law. The big red line, gross negligence, that's that tracheotomy with your pocket knife and your ballpoint pen. Okay, that's we don't.
Can you be sued for not helping?
You don't really have a duty to act.
If you're a doctor?
As an EMT, I don't have a duty to act unless I'm on duty. I'm called to go to that incident in my jurisdiction. If I'm driving down the road through Davis County and come across a car wreck, I'm not legally obligated to stop and help anybody. Morally, it might be a different thing. Legally, no. Yeah,
Is there a code of ethics or something like that you take?
no, there's not. There's not. There's, in order to have successful tort, which is what it is, a lawsuit. First off, they have to show that they have to prove 4 things. 1, that you had a duty to act. 2, that there was actual injuries. That your actions or inactions caused those injuries, and that so that you were negligent in any of that way. So that your duty to act, causation, or injuries, causation, and your direct actions cause that, or inactions cause it. So, always ask if you can help somebody. You know, when we talk about patient care, we walk up and we are arms length. Hey, are you okay? My name's Corey. Can I help you? Sure. Okay, great. Okay. See, and that's all we're doing. We're getting that consent. If you walk up to somebody laying on the floor and open their airway and start doing mouth to mouth on them and they're taking a nap, they may not like that. Okay? So always check, it's always good. Yeah, and just ask, can I help you? And if they say no, then you go, okay. Implied consent's a little bit different. That's the person that's unconscious and they don't have that option to answer you. And it's implying that a reasonable person in a similar situation would say, yes, please help me. And that's what the different types of consent are. Minors and children can't really refuse treatment. Their parents can or guardians can for them. So when we go under minor consent, it's assuming that if the parents were there, they would want us to help their child. Refusal, conscious, mentally competent adult can refuse no matter what. They can say, no, don't help me. Confidentiality, once you start helping somebody, again, everything that you learn, hear, and see becomes confidential information. It's protected privacy information from him. Minimum fine on that's like $50,000, so be real careful with that one. Abandonment, when you start treating somebody, don't leave until somebody of equal or higher medical authority has arrived and taken over care. So when you start helping somebody out here in the hallway that's falling down the stairs, make sure you stay there till somebody comes and says, okay, we got it from here. Okay, all the front loading of this stuff is legal. Got to get that out of the way. Here we go to transmission diseases. And I'm here to tell you, if you don't know somebody really, 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 really well, we don't do mouth-to-mouth pretty much anymore in this business. We use bag valve masks, we use adjuncts, different types of airways. In fact, we're even teaching now compression-only CPR. So we're teaching to the general public, just getting that blood circulating. There's enough oxygen in it. Pushing on the chest brings in enough air, and relaxing lets it back out. So when we're doing compressions, we're kind of doing both at the same time for them. So we're not teaching people really mouth to mouth anymore. Unless it's a really good family member, stick with that. Mexican rice the second time around is not really good. So. But you don't know what these people have. So when we talk about BSI, body substance isolation, or wearing gloves or masks, I realize you guys don't carry gloves, latex gloves or nitrile gloves in your back pockets anymore, and face masks and stuff like that. So just be real careful. I mean, if it's really bloody, don't get that blood on you, because you don't know what that person does when they're not here in the workplace, and it may scare you anyway. So be really careful. Any body fluid can carry diseases. Yeah, you guys, watch out. Okay. Best protective barriers, again, that's the gloves, that's the face shields. part of a first aid kit. How many of you have first aid kits? Anybody? You carry them with you anywhere, everywhere? You got them in your car? Do you know how to use them? Do you know what's in them? Have you ever gone through and looked, or you just take the kit and throw it in your car and go, hey, I know there's stuff in there I might use sometime. Well, I'll tell you, if you have a first aid kit in your car and it's been through a couple of seasons, go see Tiffany and get some new gloves for it. Because those things, as they get hot and cold, they get brittle and they crack and they'll fall apart. So stuff like that, go up to Tiff's office and see her, and she'll give you a couple pairs of new gloves to put in there. But take a look at the stuff. Is it dried out? Is it still good? Well, we got plenty of stuff up there that we can help you to exchange out stuff, or like I say, especially gloves and things like that. Come get some stuff from us. Let's make sure that you're taken care of and you're protected.
And if there's an emergency in this building, I have a jump kit upstairs.
Yeah.
All you gotta do is call.
Or scream real loud.
Scream real loud.
Bring the jump kit! First floor!
Or open the AED box, there's an alarm on it, and that will.
It's not loud enough so you hear it up there. Do you hear it? I won't hear it.
You won't.
I won't hear it. Okay? She'll hear it and tell me, and we'll come down. Okay? There we go. Okay? Always wash your hands. That's the biggest thing you can do to prevent the transmission of diseases. You wash your hands, and you wash your hands. So you wash your hands before you help somebody if you can, but not typically. That's where you put on gloves. But even after you take them off, you wash your hands. So soap and water does wonders for us. Little gloves, the goggles, or the glasses, and that's actually a one-way rebreather mask for doing mouth-to-mask resuscitation. Okay, again, wash your hands after using the restrooms. Prioritize patients. We're not going to hit that. Patient evaluation. This is where we want to get into the nuts and bolts. This is what you're going to have time to do in the first 3 to 5 minutes while you're there waiting for other people to come. When we talk about ABCs, airway, breathing, circulation. We talk about airway. We talk about, first off, ensuring that the patient has an open airway. We're going to practice a head tilt, chin lift in this class. You're all going to get to open an airway on each other. Woohoo! Yes! Yes! Once we get an airway open, we want to make sure that they actually are breathing. We have to get down, look, listen, and feel. Make sure that they're breathing, and then we assess circulation. If we can do those 3 things, we can make a huge difference in somebody in their survival rate just by taking care of the ABCs. We feel the temperature. We feel their skin. We talk about CTC, color, temperature, and condition. And we're assessing the skin. That tells us a lot. What color are they? Are they red? Are they blue? Are they gray? Are they pasty pale and wet and cold? That usually means they're having a cardiac problem. So when we start looking at that. Poor gray or pale, poor blood flow, red or flushed, carbon monoxide poisoning or heat injuries. Blue is a lack of oxygen. Meaning we're not getting perfusion. Perfusion means that we've got blood circulating through the body and it's got oxygen in it and it's going out into our cells and it's exchanging oxygen for carbon dioxide. So if that's not happening, our skin starts reflecting that. Dark pigment patients, we look at the fingernails for the changes, or the eyelids. Pupils, normal response to light. These are all things we look at really quick. Are they unequal size? Some people, that's normal. Other people, that means they might have a head injury. So that means if they have a head injury, they probably have head injury, back injury, spinal injuries. We look at mechanism of injury. We make sure that we start taking precautions to minimize any further risk. A lot of this whole deal with this initial assessment is making sure that the patient doesn't come into further harm. So constricted pupils may be drug or central nervous system disease. But it could be, if they're constricted little tiny pinpoint pupils, we have this thing running around our town called meth. Got a lot of that out there these days. Dilated pupils, they can be unconscious. If we open up the eyes and the pupils are just absolutely great big, and they're not responsive, they probably truly are unconscious. say truly are unconscious. We have a lot of what we call peaking comas, people that fake being unconscious, but that's another story. And here's our pupils, unequal, dilated, and constricted. Normal level of consciousness, people know what's going on. Hey, they know who they are, they know where they're at, and they know what they were doing. They don't always know who the president is. We don't need to ask them their date of birth because we don't know what their date of birth is, right? When's your birthday? I don't know. Me neither. Okay, good. We're on the same page. Maybe I'm unconscious. Maybe I'm delirious, right? I don't know. But they know who they are. They know where they're at and what they were doing. You know, so person, place, and time. What happens? Alter level may be confused, disoriented, unconscious. Inability to move. Hey, kid, would you grab some gloves? All different sizes, please. A box of each. A box of each. Inability to move. Normal, they move on command. Paralyzed, can't move at all. Stroke, maybe one side of the body. Hemiparalysis. So their arm or their leg and their face may all be drooping or not work on one side. When they talk, it's just out of one side of their mouth. And sometimes really hard to understand. Reaction to pain, normal sensation. You know, if I go, can you feel my hand? Does this hurt? Yeah. Okay. Great. I'm awake. If it's paralyzed, there is no feeling. I didn't squeeze that hard. I didn't do a sternal rub. I just closed his little finger. You know, come on. Medical identification. We look for bracelets. We look to see if they have a medical alert bracelet, a tattoo, a necklace. You know, you're just looking. If you see a chain and a necklace, pull it out. See if they have a medical problem. Typically, what you'll see a lot of times is diabetic or seizures. You'll have a history of those. And you know, again, if that's the case, if it's a seizure, we're going to make sure they have an open airway. You know, and just kind of let them sit there. They're going to start coming around. Diabetic, we're probably going to start needing glucose, sugar. I mean, that's going to be a true 911 emergency too.
So I guess, so that last slide said something about where carry a medical alert. Is that just this, or like do people keep something in their wallet, or?
They do. They'll see cards in the wallets, but
I'm trying to kind of search people.
I'd be very careful with it.
Because my father-in-law, he's diabetic, but he doesn't wear anything. But I'm sure if you like stuck your hand in his pocket, you'd find it this one.
Yeah, but typically, I was going to say be very careful with that. Just because you start searching their wallet and hey, where did my $100 bill go that was in there? They might not have had one in the first place. I'm sorry, I'm just not a trusting individual anymore after 30 years of doing this. If I check a wallet, I have several witnesses there. Either my team or a law officer if I'm trying to get identification on a patient. I mean, I would pull out the wallet looking for ID and stuff like that. But again, I've got people there that are corroborating what I'm doing. But a necklace or a wrist, like I say, and we're getting tattoos on the wrist now, diabetic seizures, but they're tattooing right on their wrist. So take a look at that. I wouldn't say go searching in depth until you get more help there or an officer there.
Maybe I'll get a tattoo first. Probably.
I think you should. I think that'd be a great idea. You get matching tattoos.
I don't think Scott's that.
Oh. Okay. Well. All right. Let's throw that up and we know the end of it.
Just kidding.
Well, you could be by the time you get when you get older, so you might as well go ahead and get it now.
Pre-diabetic.
Yeah. Yeah. And then when you become diabetic, then you could just scratch off the free. Yeah, scratch it off. That would be good. There we go. Okay. Respiratory system, air passages, the lungs. Provide constant supply of oxygen. Breathing is controlled by the brain. So we start getting a balance in there of oxygen and carbon dioxide. And the brain says, okay, I need more oxygen, and it increases your respiratory rate. We don't have to think about it. It does it all by itself. We're saying, hey, this CO is getting a little stuffy up here. Let's get more oxygen going. And so the brain just sends those impulses. It's all automatic. We don't have to think about breathing. We don't ever have to worry about it. We start running, and the brain says we need more oxygen. We get more oxygen automatically. Sometimes we're breathing harder than we want to, but it just we don't have to manage it. It does it for ourselves. So you start looking here. Got the nasal and the oral passages come back, meet together at the back of the throat, come down in here. We're not going to worry about all these parts. Air comes in here, goes into the lungs, gets pumped out into the bloodstream, comes back, goes out. Pretty simple, right? Okay. A normal adult, they breathe 12 to 20 times a minute. So we consider abnormal breathing above 30 is what we talk about. It's above 30. Can I get a couple volunteers? Great. Come on. Relax. Have fun. If I'm assessing a patient, can I look and can I see normal breathing? Breathe in and breathe out. And breathe in and breathe out. Welcome to the spa. Thank you. I want you to breathe 30 times a minute for me. I want you to breathe fast and loud and hard. Okay, buddy?
All right.
Okay. No, that's not 30 times a minute. Keep going. Faster. Louder. Come on. Faster. Deeper. Just calm down. Calm down.
I'm seeing a little excited.
Relax there. But you can see that. You can look at somebody and go, they're having trouble breathing. They're having a problem, right? I don't have to stand up here and count 1, 1,000, 2, 1,000. Where was I at? 4. Was that 2 or was I at 3? No, you can look at them. Thanks. But you don't have to sit and count and measure and everything else. You can look and go, wow, they're breathing way too fast, or they're not breathing effective. Very simple for us. Respirations, are they absent, slow and fast, shallow and deep, gasping, labored, or choking? We know what normal respirations look like now. Thank you. We know that. We can see that. Going, ooh, this is bad. Or just, are they breathing faster, slower, or shallower than you? Realize you may be a little excited because you just ran across the floor because you saw them come tumbling down the stairs, right? Okay. Other common respiratory emergencies: choking, drowning, poisoning, suffocation, inhalation, drug overdoses, electrical shock. They all have a problem, create a problem on our respiratory system. I want to get in here to this. Okay, here's where I want to have fun. Everybody, come up and grab a pair of gloves. Come on, come on. This means everybody. This is interactive. Everybody come put on a pair of gloves. We're going to pair you up, 2 by 2 by 2. Come on. It's easy. Come on, this is fun. We're going to have a good time.
Woohoo! This is so fun.
Yeah.
Happy hands.
Sorry, this is where we're going to lose some of the...
Maybe we could use in the kitchen to, clean cabinets and,
Put the chairs out of the way. Or let's find a spot to lay down. One of you lay down on the floor, 2 by 2.
Get out on the floor, then pick it up.
Are you not going to play with us? You're not going to open an airway? Okay. How about with me? Will you play with me? Okay. Okay, so we talked about airway first off. So we talked about opening an airway. What I want you to do is I want you to, everybody got a partner? Okay. Okay. You two work together then. What I want you to do is if you're beside the patient, I want you to just reach out and touch your shoulder from a safe distance and say, are you okay? Are you okay? And the reason we do that is because the fact that, again, they may be taking a nap. You know, they may be on their lunch and hiding in the conference room, laying on the chair, sound asleep, you know, taking a quick nap. Okay? Then I want you to take the palm of your top hand and I want you to place it on their forehead. Okay, turn it, just kind of, yeah, just like that. Now I want you to take 2 fingers and put underneath the chin. Okay? And I want you to just tip the head back. Okay. 2 fingers. 2 fingers right there. Right there. 2 fingers right there. 2 fingers. Let's see it. Okay, 2 fingers. And just tip the head back. Now put your palm on the forehead. Oh, come on. There you go. Get down and touch. Get down. Now open it. Come on. Tip the head back. Now I want you to put your ear down. I want you to look, listen, and feel. I want you to lift with your fingers on the head. You got to make sure the airway's open. No, put your fingers on the head. There you go. Okay. I want you to look, listen, and feel. Can you hear air exchange? Can you see the chest rise and fall? This is what the majority of most people that fall down or unconscious need. Typically, you don't have to do anything other than this. I'm at a casino in Mesquite. We stopped there coming back from Vegas. I got the girls with me. Got a guy that falls down. He's one of the workers, and he's unconscious. And people are going to start doing chest compressions on him. I said, whoa, calm down a minute, just a minute. Open an airway. He starts gasping. He starts breathing. A few minutes later, he's totally responsive and talking to us. That's all it takes. A lot of times, is just opening that airway and making sure they have an open airway and they can breathe. Trade places.
So Corey, the whole purpose of pushing the head back.
It'll open the airway. What it'll do is it'll pull that tongue muscle from away from the back of the throat. Because as you're laying on your back and you're unresponsive, that tongue will relax and fall against the back of the throat. The most common airway obstruction in an unconscious adult is the tongue. And by doing that simple head tilt chin lift, it pulls those muscles away from the back of the throat. So trade places and now each of you open an airway. Okay? All we're trying to do is get that airway open.
Oh, I gotta keep it there?
Yeah. Now look, listen, and feel.
I was joking on something.
Okay, while you're there, take a quick scan down the body. Do you see any bleeding? Do you see a pant leg that's turning red? Yeah, he got a bleeder. He cut himself shaving. Call 911. Yeah, I mean, and really that's what we're trying to do. But now take a quick look down there. They talked about checking the skin, checking the color, temperature, and condition. Feel the arm. Does it feel warm? Just touch it. How does it feel? You can feel it through your gloves. If it's wet and sweaty, I mean, you can feel it. You can check it. The other thing we want to do, I realize your patients all have gloves on them, but we're going to check capillary refill. Now you're going to swap and do. Everybody can do this again. Put your finger on the middle of the forehead and push. Okay. When you let go, there's a little white dot. Okay. It should disappear within 2 seconds before you can say 1 Mississippi, 2 Mississippi, before you can say capillary refill. That's saying that we have good circulation. You can do it on the fingernails. You can do it on the webbing on the palm of the hand, or you can do it on the forehead. Just a real quick check. Take a look at their eyes. Are they equal, round, reactive? Okay. Take a look at them.
Very cool.
Okay. Trade places again. Trade places again. I want you to open an airway. I want you to check capillary, or take a quick scan. I want you to check capillary refill. Not on your own forehead, you can't see it. You gotta do it on somebody else's forehead. All right, yeah. Okay, come on back up. Now we all know how to open our reading the head tilt chin, right? Okay. And again, that's exactly what it does, is it pulls that tongue passage, or that tongue from blocking the air passage, keeps it from doing. Then airway obstruction. That's a little bit different, right? If we tilt the head back and they're not breathing and we decide we're gonna try it, or we see them choking and they go unconscious. Okay, so head tilt, chin lift. We talk about the jaw thrust, that's almost impossible to do without, so we're good where we're at. Infants, airways are much smaller, can be blocked by tilting the head back too far. We talk about putting the infant in a sniffing position. So everybody sniff. Okay? Like you're sniffing, how you kind of just extend your neck just a little bit, you kind of pull up there. That's called a sniffing position. So you just barely tilt the infant's head. We don't do a lot that way. We tilt it too far, we can actually create some problems. Putting your hand underneath their shoulder blades on an infant is enough to open the airway. It's enough to get that position. So a little tiny head tilt, very little. Choking, conscious adult. Has everybody taken a CPR class before? Okay. And we talk about doing abdominal thrust. So on the conscious adult, we come behind and we make a fist. We put it right at the belly button. And we take your other hand and we pull inward and upward hard, right? Trying to expel it. That's the only other person that's got a totally obstructed airway. If they're telling you I'm choking, they're saying I'm choking, we don't interfere, right? If they're coughing, we don't interfere. We encourage them to cough and try and expel that object. Don't do back slaps. Especially if they're standing up, that causes it to kind of come down and further into the airway. So encourage them to cough, keep that going. Unconscious adult, we're going to do the same thing. We're going to straddle the thighs, and we're going to place our hands at the belly button, and we're going to push up toward the shoulder blades. And we're going to keep doing it until that object pops out and they start breathing. Infant, there we do the back slaps and chest thrusts, 5 and 5. 5 back slaps and shoulder blades, roll them over, 5 chest thrusts, just like we're doing compressions, and then transventilate. We talk about rescue breathing.
So Corey,
Yes, sir.
how big do you consider an infant?
We consider an infant under the age of 1 year. Okay. Anything else is considered a child, from 2 to 8. So the air we're breathing is 21% oxygen. If we're going to do rescue breaths for somebody, we're breathing 21%. The air we exhale is 16% oxygen. So we're only using roughly 5%, right? So we've still got quite a bit. So we can still give 6% oxygen or 16% oxygen mouth to mouth. It's not the 21, but they're still getting plenty of oxygen. Mouth to mouth.
Sounds like you do.
We'll hit this really quick. We open the airway, check for signs of life. And if we're going to do rescue breathing, we do it 1 breath every 5 seconds. Whether we're using an adjunct, a pocket mask, a shield. A lot of people, they may not be breathing, but still have a pulse. So we're not going to be doing chest compressions on those people, right? If we want to give rescue breaths, then we pinch the nose, put the mouth over the mouth, full breath, 1 every 5 seconds. Okay? And with that, that's what we want to cover today. Any questions for me?
So chest compressions, you said 30, 20?
That's changed. It's at least 100 a minute now. New guidelines just need to be updated. It's at least 100 a minute.
As we just go.
Really fast.
Yep, we're doing 100 compressions a minute
And
these
it's
days.
not staying alive,
Just
staying
staying
alive.
alive.
Yep,
Yeah.
yep. Or another one bites the dust.
I like staying alive.
Either song works, yeah. Pretty good video on that, but yeah. But they both have about the same cadence. They both give you about 100 beats a minute. Okay? Anything else?
If you do come across someone, I know that's hard to do that, that many times for, especially, the 5 minutes it takes to get somebody here from the ambulance, so good to just yell at somebody.
Absolutely. First thing you do is yell for help. Help! Call 911. Then come back. Grab the defib on your way. That's what's nice about having one in the building. Everybody knows where it's at, right? Right out here on the second floor. Let's grab it. Here, let me. Okay, turn the alarm off when you grab it.
Really? What am I grabbing?
Just grab it.
The AD.
Behind the door.
Where is it? Right there by the fire.
Behind the door.
There's a reset in here somewhere. Oh, right there. So you grab the AD. The first thing you'll do is you'll turn it on.
Call for help. Remove pads from package in back of unit. Apply pads to patient's bare chest as shown.
And it shows a picture on the pads where to put them.
Apply pads to patient's bare chest as shown.
And it won't go any further until who wants to put it on?
Apply pads to patient's bare chest as shown.
But it will tell you, it tells you step by step how to do it. So you'll grab these, you'll put them on. You put one patch up here on the upper left hand or right hand side of the chest. I forget which side I am right now. And then the other is going to go down here below the heart. Basically, you're drawing a line between the two pads, and the heart should lay in the middle of it, so that when you actually hit the shock button, the electrical energy goes between the two pads, and it dissipates, or it's concentrated in the heart, is what it does.
And that's if they're gray. Don't do it when they're red.
If they don't have a pulse. Yeah, if they don't have a pulse, you put it on there. But the nice thing about the AEDs is they will not shock unless there's a shockable rhythm. They're either in ventricular fibrillation. That means the ventricles are firing so fast and the heart's just quivering. There is not a palpable, you can't feel a pulse. But that heart is just shaking. It's ineffective. It's not pumping blood. Or the other one that it will shock is supraventricular tachycardia, meaning the heart is going so fast that it's not able to effectively pump blood. So you put the patches on, and it will automatically just take over. As soon as you put those patches on it and it makes connections, it will say, stand clear, don't touch the patient. And now it's going to it'll say analyzing, and it'll start analyzing. And it'll say no shock advised or shock advised. If it says shock advised, then it'll say make sure patient's clear. So I'm clear, you're clear, we're all clear. Make sure nobody is touching that patient. Nobody is touching that patient. And then you hit shock. And the patient will convulse a little bit, and it'll say continue CPR. You'll continue CPR for 2 minutes, and it'll say reanalyze it. And then you back off, and it'll tell you what to do. Don't be afraid to use it. It's scary, but it's it is absolutely. Yeah. They draw you a picture and they give you instructions. I don't know what more. It's simple. Don't ever be afraid to grab it and use it. Yeah. Talk slow and calmly. The biggest thing is make sure nobody is touching that patient. Because if they are, they're going to receive that same level of energy to their heart, and it can stop the heart. Because what it really does when this electrical impulse hits the heart, it actually stops it for a brief second. It stops all activity. So if it's quivering, if it's ventricular fibrillation, it stops it, and then the hope is that it restarts in a normal situation. It goes back to a normal beat. And that's typically what it does. But early defibrillation and CPR is probably the biggest, it is the biggest chance of survival for anybody that goes into sudden cardiac arrest. So that's why they're here. All the deputies have got them in their cars. We've got one here. There's one up in our office. Just holler for help. Get 911 calling and get this thing and start doing your ABCs on the patient. Okay? Good question. Thank you.